As we talked about yesterday, we have our Department of Rehabilitation and Corrections Director, Annette Chambers-Smith, with us today on Skype to give an update on prisons. Director, thank you for joining us. And joining her, as looks like 6 feet apart there, is Dr. Michael Pera, who is Professor Emeritus in Infectious Diseases at The Ohio State University College of Medicine with over 40 years of experience in medicine. So I'm glad to see both of you there. And Director, why don't you start by kind of giving the people of Ohio a report on what you're doing to keep staff safe and prisoners safe as well during this very, very difficult time. Director?
Well, I certainly want to thanking people for getting us and for making sure that we have things that we need to have this disease. Those of you know that we had a pandemic plan for H1N1 long before we ever had this flu. COVID is not when we started planning. We started planning in 2009 with H1N1. And ironically, I was the health authority for the department during H1N1. And it was during my time, my years as the health authority, that we created the pandemic plan to begin with. Little did I know, flash forward to 2020, we would be dusting it off and implementing it, as well as changing it with the shifting science of COVID-19. So I guess my point behind that was we didn't just start in February or January. We started quite some time ago. We have practiced our pandemic plan in the past, and we knew how we were going to start with this. Every institution has its own plan that's tailored to its physical plant. And when COVID-19 started, we did ask every facility to update that old pandemic plan to make sure that it accounted for what we knew about COVID-19 at the time, because we know a lot of different information now than we did then, and that we were making it fit the current physical plan, et cetera. So we did tabletop exercises in February. We did begin to try to procure PPE. We put a commodities strike force in place just to make sure that what PPE we had was appropriately shared until we could get some in. We realized quickly we weren't going to be able to buy it in any kind of quick fashion, so we decided that we would start making it. And the penal industries started making hand sanitizer, face shields, and also like a surgical mask, as well as the tailor shops in all the prisons did begin to make PPE for the people who live in the prisons. There were several different means, not just the statewide PPE task force, which has been fabulous, but also our own internal commodities team. We also did things like changing our policies. We normally don't allow hand sanitizer with alcohol, for example. We normally don't allow certain types of wipes with chemicals in them. It's just different in a prison environment. So little things like that were waived or changed so that we could make sure we had the policies necessary that were going to support this pandemic as well. We think of it as layering. We're like the second prison in the nation to stop accepting visitors. When we did that, everyone thought we were excessive and moving too fast, but we knew we needed to try to keep COVID out of the prisons, because once it came in, we would have very little success with stopping it. So a lot of our plans were around preparing and trying to keep it out as long as possible. We were able to keep COVID out of the prisons until the main surge in the free world happened, so that our surge and Ohio's surge happened slightly different timing, which is good, so that we were able to all have the services that we needed of the hospitals in the various zones. There's a lot of different things that have gone on, from masking to gloving. We were already in flu season, so we had cleaning teams already operating and had already offered the flu vaccine to our population and to our staff. However, with COVID, we knew that it was going to be important to make sure the types of chemicals we were using actually killed COVID. So we did check with the CDC and EPA on that, and we knew exactly what chemicals of all those chemicals we normally use would kill COVID. So we narrowed down to just using those chemicals. We stopped people from moving from prison to prison. We stopped doing I will never call it an elective procedure, but a procedure that could be delayed medically. We changed how we provided programming, how many people were allowed to be together. We began to cohort the people who lived in the prison into their housing units like a little family. And then we eventually started cohorting staff. And every time we have done a contact tracing, we go back to what we've done and say, okay, is there anything we can do better? The CDC has visited one of our prisons to provide advice to us. And also we get the help of an environmental health physician who he works for OSU. His name's Dr. Weir. I think you had him on already. He looks at our plans around social distancing and movement and how we handle our HVAC systems. There's literally no part of the prison system that hasn't been touched by what we're doing to try to deal with this pandemic. So that's been going on since February. I think all of those things like changing how much fresh air comes in with the HVAC system or the filtering or ordering different supplies to try to clean the air. It's a lot of different things going on, and I think a lot of staff pouring a lot of time into it. Our staff are working double shifts as we have people that are ill. We've gotten help from the National Guard because we need to replace the people that aren't able to work. And the National Guard does bring people into us to help us do our checks on people in a prison. It only takes one person being positive, either a staff member or an incarcerated adult. If we get even one person, we put them on a different status that we call red, and at that point we take signs and symptoms and temperatures of every single inmate every day. In those prisons where we have short staff, the National Guard helps us do that. We also use the Highway Patrol to do perimeter patrol at several of our prisons, and that allows us to bring our staff inside and make sure that we can work safely. Literally, from the Iowa Department of Health, the OSP, OSU, the National Guard are all working together for the betterment of the people that are living in the prison and to make sure that we can take care of our environment. They're definitely, it's a team. It's a team, and it's been refreshing because I don't think all of my peers enjoy such support. We are trying to leverage the best science as soon as we find out about it. So, for example, we started staff screening in March 11th, which consisted of asking the questions that the CDC recommended at that time, signs, symptoms, travel, et cetera, and taking temperatures. So we started doing that then, and I think we're on version 8 of that intake form for our staff because the CDC has literally changed that recommendation based upon science coming out and further information. So we keep up with that. This is really a collaboration, and our physicians do collaborate with doctors across different disciplines to come up with our overarching plan. I asked Dr. Parra to be here today actually to kind of talk about our testing strategy. As you know, we were the first state to do mass testing anywhere. We did mass testing at 3 facilities. We tested every single person that lives there, and by Friday we'll have tested every single person that works there that wanted to be tested. And we learned some valuable information that is helping us build our plan moving forward of how we would do testing. Dr. Parra, did you want to speak to that?
Thank you. Thank you for asking me to look at the plan. I have to say, Governor, that I've been overwhelmingly impressed with the director. The fact that she knows so much about this, I guess it's because she was the health authority for the system, and her assistant was the health authority as well. And so they're very familiar with this, and they really know what they're doing and honestly understand how to approach it in this environment. And as you've heard, she did this with the swine flu, where she helped develop this plan. And this is just, we've learned more. It is a new virus. But still, infection control is infection control of respiratory agent, and so she's very familiar with them. I think you're lucky. I think the system is very lucky to have her, because I've been very impressed with this. I've talked to the medical director about some of these situations, and he seems to be very familiar as well with it. And so, I mean, I've been studying infectious disease and viruses for 40 years, and have recently come on with the COVID effort at the university. And so start looking through things. And you mentioned the testing at the Marion facility, and I think that was a critical step, because we learned so much from that. Approximately 80% of people were positive. Some went to the hospital, but what was most amazing, and I think this is kind of national news literally, is how many people were positive and had no symptoms at all and were feeling fine. What does that mean? That means that if they let a lawyer in or send an inmate to the court, they could run into somebody who had absolutely no symptoms at all and have it. And so one of the issues that I was asked to look at was, should we test everybody in the system? Well, testing everybody in the system helps today. But if somebody goes to court, or a lawyer comes in tomorrow, they can bring it in all over again. And so the scheme that she has to monitor people, anybody that's sick gets tested, anybody that's sick and is tested goes to the infirmary. They're tested for the virus there. If they're sicker, they go to the hospital. If they're not sicker, they stay in that infirmary. And everybody, as you just heard, everybody in the prison gets tested every day for fevers or symptoms. And if, again, anybody that gets sick gets moved out. So I think it's a very good system. As you've just heard, Dr. Weir made some suggestions on changing the physical plant. They've educated the inmates about this. They've offered them masks if they want to wear them. They're making the masks. They participate with the governor in the early release program. They do contact tracing. There's really very little else I could suggest. I mean, honestly, she's thought of a lot of things and talked to a lot of individuals, and really has done a lot. There's one can't deny it's a closed environment, but she has cohorted these units. I was impressed with this. She cohorts units, and the guards are assigned to a unit. The warden's assigned to a unit. They don't really communicate with a lot of other people. And so that is cohorting in one aspect. So I don't know what else I can address, Director. You really am impressed. Thank you.
I appreciate that. I did not pay him.
No. The university pays me. No, you really are. I am overwhelmed, actually, at the thoroughness of what you've done.
Director, I wonder if you can address a little bit, and also, Doctor, we've had this discussion. I had a discussion this morning. You tested, I guess, virtually everybody in Marion. But the idea, Doctor, you raised the idea, does it make sense to test everybody in the whole prison system, 48,000 people? And you all gave me an answer to that question that I asked this morning, but I wonder if you want to discuss that a little bit and explain to the public what the procedure really should be in regard to testing, the protocol should be. That's either one of you, Director, or either one of you want to start.
Do you want me to start, Doctor?
Go ahead.
So the reason we tested everyone in those facilities is because Marion Correctional Institution has a significant number of people that are older with comorbidities. Franklin Medical Center is actually sort of a prison hospital. It's a step down from a hospital, but not quite like as if you were at home. And then Pickaway Correctional Institution has a 68-person dialysis unit, as well as a long-term care facility with a prison wrapped around it. So those were three populations that were very vulnerable, where we had some amount of COVID and wanted to test to see if we could find the people who were asymptomatic and positive and then separate them physically from everyone else. When we got the results back from Marion, there were so many people who were asymptomatic and positive. We knew that everyone who lived in that prison had had exposure, and the separation wasn't going to work. So had we got what we thought we would get when we had our original hypothesis to test everyone, which was a discrete number of people in the prison who were positive and asymptomatic that we could move out. We were getting ready to open up another prison and move those people in there so that they couldn't infect anyone else. That was our idea. But the science told us something different. There's way more people that are asymptomatic and positive than any of us really ever dreamed, actually. And so then the clinicians looked at, okay, here's what we found. We're going to retest the negative people and see if those people in those mass tested facilities turn positive, which we have started doing already, and some of them have. With this type of information, the decision was made to do spot and sample testing as ordered by the clinicians, testing of people who have signs and symptoms, testing of people who are being released, and sampling and surveillance as ordered by the medical director. And what our hope is here is that we take care of the people who are sick, because we found so many people who are symptomatic that have literally nothing wrong with them. We check their temperatures and do signs and symptoms every day. The reason we do that is so that if anything starts to go wrong for them, the healthcare staff can intercede immediately. So this is what we've been doing now, and the release testing will begin next, so that we know when we release someone out into the facility, from the facility at the end of their stated term, we can tell the people in the local health department, this person is actually positive instead of this person has had exposure. So that's sort of what the plan looks like now. Did you have anything to add to that, Dr. Para?
No, I think people are quite well aware of the fact that if you're fine, when you're not in the system, you don't get a test either. It's like you can just walk in and get a test if you're feeling fine. And so I think your approach of looking for people who are sick, testing them, get them into the facility, that takes care of the people who have it. And once you know that it's there, keeping a very close look over the rest of the people to see if any of them get sick and get them into the treatment, that meets the needs. You want to, as you said, you want to take care of the well people, not the people who are just, carrying it, feeling fine, or not even know they have it.
I think the other thing we've done to try to figure out, other than our symptom checks, we no longer charge a copay fee with regard to flu-like symptoms. This should remove any barrier to the person who's incarcerated from wanting to seek health care on their own, which they can do either by talking to the officer or using the health service request process. So they have the ability to do that as well. It's not just the surveillance. And we also changed our electronic health record before we ever had a case of COVID, so that we could do analytical surveillance on the back end and see if we have a spike of certain symptoms that tie into COVID. We will triangulate in on that just based upon what's recorded in the health records and in our analytics that we do every day, and say, oh, we have a spike in this prison. What is causing that? What can we do? Where do these people live? And start going after that in a different way as well. So we're not just relying on temperature checks and symptoms, although that's good. We also have the ability for the people who are incarcerated to request at no charge, and we also use our health record to surveil what's going on.
And your physicians at the institutions look out for the people who are more susceptible or immunocompromised. They look at them more carefully to be sure that they don't get this, or if they may be tested before anybody else simply because they would be the most susceptible ones. And so again, they use your records, and you know who's in your facilities.
Director,
I would also tell you 40% of our people are living in cells. And the people that live in cells, some of them are double, some are single, but those folks in cells are very protected because they're not permitted to come out of their cells unless they have their mask on. And they're not really interacting with a lot of other people. And even then, they're living in a unit, and that unit is a cohort and moves around together. So they would eat and recreate and live together. So it's a lot easier to control in an environment where there's cells. That means 60% of our people live in an environment that is open bay housing. Some of these might be as small as 40, and I know one's as big as 300. So it's around 100 to 125 people in what we're calling a cohort. And what we try to do is get those folks in the cohort to not interact with any other cohort. That's how we try to protect them. And then we take the staff and put them in cohorts. They may have 3 cohorts that they're associated with that are inmate cohorts, but our staff are not all mingling with each other. So these are things that we have layered on over time. I mean, we started having people sleep head to foot. That was another way to get literally their mouths farther apart. Sorry.
Director, let me ask a question in regard to the staff and protection of staff. You want to talk a little bit about how you're dealing with the staff?
So we have started testing staff, as I stated. Why I have to cough now, I'll never tell you. But they have PPE equipment that matches up with the ODH and CDC guidelines. So what we did was we took the guidelines from CDC and ODH and put it in a graph. We have one graph for people that are healthcare professionals and the things that they're doing, and also the incarcerated adults that work in the healthcare area with those staff. And then we have another chart for people that are not healthcare professionals and the things that they do, and the incarcerated adults that work with them. And it'll say, I'm doing X activity, I would need, I might need a gown, an N95, a shield, and goggles. That's like an aerosolizing procedure in medical, right? Or I might just be a correction officer who is watching a unit. At that point, I would need gloves and a surgical mask. So it all varies according to what you're doing and where you're doing it, and it's in a chart. So that was our attempt to utilize our PPE because, you know, we're trying to buy it, we're trying to make it, and we're also trying to conserve it and use it responsibly. So that's how that plan went. We also set up for any of our hotspot prisons the ability to go to a hotel after work so that you could take a shower and just go home after that if you want to, or so that you could check in and sleep the night and not go home. That's not something we mandate. That's something we make available because we want our staff to have the ability to make sure their family are safe and to make sure that they have what they need to change and do things like that. I know that Dr. Acton always talks about all heroes don't wear capes. I think heroes might wear gray correction officer uniforms, actually. They are coming into a prison where they know good and well there's over 2,000 people that are COVID positive, and they're doing their jobs every day, and they're amazing. And then we have about 2,000 healthcare staff who've chosen to work in the field of corrections, and those folks come in and they care about their patients just like the people who are caring for patients that aren't incarcerated. In our long-term care facility, when the CDC came and met with our staff, all of our staff, our correction officers and our healthcare staff, one thing they kept saying over and over was like the rapport between the patients and the people that work there and the caring, they weren't expecting that. But that's how we operate, and they care about their patients just like the patients are cared for out on the streets. And they do everything they can to take care of them. They're invested. They're working double shifts, back to back. That's why we have to use the National Guard's medics to help us so that we can, give our people some relief. But we use the National Guard to assist us. We use the Highway Patrol to assist us. We do offer testing. We have set up a system through OSU where they can make a phone call to get fast track the testing, and various things around PPE. We have teams of incarcerated adults whose job it is to clean surfaces. That's all they do all day. And the high touch points and surfaces so that we can try to make sure it's not passed like that. It's really layering of one thing on another. First, we stopped unnecessary people coming in. Then we stopped unnecessary movement from prison to prison. Then we stopped unnecessary movement inside the prison. Then we have about 2,000 of our workers telecommuting now so that they aren't mixing with our prison. They're still doing their job every day and they're working hard, but they're home and they're doing it long distance and they're being creative. We switched from having 3 meals a day to having brunch. The only reason we did that was so that that's just that much more time to sanitize between different cohorts eating, as well as it's more ability, the more meals, the more ability to interact with the more people. So we have 2 meals now going on. We basically put breakfast and lunch together and are serving slightly more calories than we were before. People are allowed to take food back to their unit. They don't have to consume it all right there. So those are the things like that are about just not having as many people interact with as many people. We did do 40 hours of COVID leave so that we don't want our staff to have to come in sick or make a decision between a paycheck and taking off. We do screen our staff every day and we don't let people in if they don't pass the screening. So there's a lot of layers to this. And it's all about either surveillance or prevention or, containing.
I want to see if Dr. Acton has any questions. Dr. Acton, do you have any questions at all?
No, I just really want to thank you, Director Annette Chambers-Smith. I've said this before. My colleagues and I around the country talk quite a bit, and the director has been someone that all my peers have looked to. They talk amongst states. I really think the plan was an amazing plan. We know it's a difficult situation in any congregate setting, and so again, it's an honor to work with you. And we're not trying to overbrag you here, but I think Ohioans should know that we've been very fortunate to have someone who is very compassionate about everyone from the staff to the prisoners. And I've seen that in her before there was ever COVID. And in these hard days, I've just seen it in her every day. And Dr. Para, thank you so much as well.
No, it was a pleasure for me, honestly, seeing all the processes that the director put together, as well as how it's evolved and gotten better and better. As soon as she sees something that would help, she implements it. It was very impressive. I mean, you want a job in infection control at the hospital?
I just might one day.
We would love to have you. Wow, I'm impressed.
Well, I really do appreciate you guys saying that. It's not an easy time. We did have 2 of our own staff pass away, and that is horrible. The incarcerated adults that passed away, horrible. We don't want to see any of that, but I don't think we can expect to not see any deaths when we see the same thing happen outside of corrections. But we will dearly miss Officer Dawson and Nurse Reeves, Well,
Director, thank you very much. And you mentioned Nurse Reeves, 58 years old, of Blacklick, a licensed practical nurse at Pickaway Correctional, tragically died last Sunday night. She began working there in 2006, first as a health information tech, before going back to school for her LPN. She was working to become an RN. She was most recently working in the pill call area in the dialysis division. She leaves 3 daughters and grandchildren. So our heart goes out to her family, and we are just very, very sorry for that great loss. Director, thank you. Doctor, thank you very, very much.
Governor, they did ask me to speak about early releases. I think several people were wanting to hear about that. So did you want me to go on?
Sure,
now?
No, absolutely. Anything that, any questions you got?
Well, we really started talking about this in early March. how we might do it, how we could keep safety as well as try to reduce our population. And as you know, under your leadership, we decided to go with a full continuum approach, which involved the courts all the way through to the parole board and your own clemency powers. So there's a lot of different irons in the fire and people being released in different ways, from judicial release at the court level, or even from diversions, for that matter, at the court level. And then for us, we have, we're reviewing people who are PRC violators. We are reviewing people who have been continued by the parole board. And we have also gone to the legislature, the CIIC, to enact the early release clause that's in Ohio law. And then you yourself have done some commutations, clemencies. All of this tied together, our population has decreased by 1,379 people since March 24th. So I think sometimes people get wrapped up into looking at one process or another and fail to realize the totality of the entire continuum has had that effect on our prisons. And what that's allowed us to do is go into the prisons and make people the ability to live farther apart and have more physical plant space, which it's a nicer way to live, period, but it's also a part of our trying to fight the spread of COVID. We can't change our physical plant and that make cells, but we can try to have people live farther apart. So we've used this space that's been created by the people who are no longer incarcerated and we've used non-traditional housing like tents and gyms and classrooms and chapels, just simply to have more space between people and to have different size cohorts. We continue to do rolling early releases. So those are, today I have 91 days left, tomorrow I only have 90. Therefore, I become eligible tomorrow. So we are continually doing that, as well as we've reviewed the list of people over a certain age and applied the criteria, which you'll be getting presented with another list of people that we think would be good vets to leave. Now, naturally, we're trying to do all this in a way that doesn't result in what we've seen in some other places, which people leave and either reoffend immediately or kill someone. I mean, that's the worst case scenario. We don't want that. So we do want to have a reduction. We want to do it safely. This is the method Ohio has chosen, and this is how many people we've been able to impact.
Director, thank you very much. Doctor, we appreciate your time, both of you.
Okay, it's National Employees Week for corrections people next week, and it's also Nurses Month. So I gave you a little video of our staff, and I'd just like to say you guys are doing great work, and I appreciate you.
All right, we look forward to the video. Thank all those who work every day in our Ohio prisons.